Okay. And then I'm just going to go over here. Um, and I had just waiting for my thing to come up live. There we go. So Instagram should be going on now. So anyways, like I was saying, we were just talking a minute before we got on here. But being in Denver, it's it's not as warm as Arizona, so that was interesting. And got to learn new stuff. So hoping tonight we can talk to a lot of people and let them know about some of the new stuff coming out at ASRM. We kind of go from there. I want to start it off by talking about last time we had that show where we discussed what we thought were some of the most revolutionary things. And one of the things you brought up was PGT testing. And when I came to the conference, I was expecting to see like a lot of new research and things like that. But one of the biggest things that really is still developing is PGT. And just like you said before, it still is kind of the forefront. And now what people are doing is changing it in the way we did before. And so I know once we spoke about like the iterations of PGT that have occurred over the years. So there was, in the very beginning, fish. So where you actually had like a probe go down and find something. Then you had the iteration of CGH arrays. Then you had SNP technology, and then next-gen sequencing, which is we're actually sequencing everything. And so one of the cool things that is coming out, and I'd love to hear what you think of this because I thought it was really cool, was instead of using a DNA polymerase, when we're amplifying the DNA with whole genome amplification, instead of using a piece of DNA, what happens when it amplifies, it keeps repeating itself, copying. And so it's copying copies of copies and stuff like that. And so if something falls out, which we call dropout in your development, then it's going to have the copy of that. And so anyway, so one of the cool things is, and I think we talked about this before, is now they have like a primer that only duplicates the original DNA. Mm-hmm. And so that allows to prevent some of that dropout. So anyways, one of the factor,
high fidelity signal. That's kind of, like the accuracy is higher.
Exactly. So anyways, I thought that was one of the really cool things. So now currently only one company has that. So then the other big focus on PGT was one, higher resolution. So one of the first things that they're doing is they're adding now SNP arrays to the next gen sequencing. And so one of the cool things about that now is now we're able to look at I don't know if something you want to like start with to kind of explain, like with next gen sequencing, one of the limitations, because it's normalized, meaning, if you have all the data, you're not actually looking at copy numbers. Mm-hmm. You're just looking at a relation to the copy numbers. Right. And so one of the cool things with the SNP technology now is now we can actually look at things if there are some copy number differences.
Yeah. No, I mean, it's fascinating. And so you're right at the forefront of this, right? You're obviously, like, I think I was mentioning this earlier, but just to all our guests out there, you're at ASRM 2024. It's kind of our main conference out there, American Society for Reproductive Medicine. And it's this great, collaboration between like PhDs and MDs and nurses and everybody in the industry, and just kind of everybody's trying to bring the newest cutting edge medicine to the forefront and see what is actually beneficial for patients. And I think that's probably one of the really interesting parts of our job as physicians, as REIs, is that, there are a lot of people making cool gadgets out there or cool tools, but we have to actually kind of dissect out what's valuable here for our patients. So, and I think you're getting to you were talking about this a little bit, this is kind of like one of these really interesting things that we're talking about, next generation sequencing. So like when we're thinking about PGT, pre-implantation genetic testing, to kind of assess out, hey, are these embryos normal or are these embryos not normal? We're getting better. The tool is getting better and better and better. And I think one of the things that you were just filling me in on is how this tool is getting better. And I'd love to hear a little bit more, from you, because I know you're right there. They're presenting the research. Down the you're in the hotel there. So what kind of things are they talking about that's making our PGT tools better?
Yeah. So again, going from next gen sequencing, which can, let's say, for example, if you had what's called a triploid, so you had triple the DNA, you would not be able to see that in regular NGS. So one of the things all the companies now are doing, adding SNP technology, which are these little portions in the DNA that we know should be there. We can see if they're there or not. And that's going to allow them now to be able to tell you if you do have 3 pieces of DNA in there. They can now see it, because before, when you used to take the data, you would take all the data and normalize it by dividing by a certain number, and then you would get to find out if anything was higher or lower. But the problem is when there was 3, it looked like it was just all across the board equal. So that allows that. That's one of the biggest things. Now, some companies are much higher resolution, some are lower resolution. So most of that's being used to be able to tell things like paternal, maternal, where it comes from, any problems like that. But one of the cool ones that I saw, and actually here, let me pull up that slide, because I actually have a slide for this. It's not the greatest slide in the world. So I apologize to anyone who can't see this very well. I don't know if there's a way if I can amplify it, but this is one of the things that we're talking about, was the benefits of early detection of certain diseases that due to deletions and duplications. And what that means is there's these little small micro deletions or micro duplications that can occur. And some of those can actually lead to very significant diseases. And so one of the cool things is that this company, which is Cooper Surgical, they are now going to make, as part of their platform, they're going to start looking for some of these diseases. So for example, like on there, it says DeGeorge disease or Angelman syndrome. And so these are deletions and micro deletions that can occur. So before, PGT really couldn't find those. They were just very tiny. But what's really cool about this is not just the fact that they can find it, but I thought the thing that was really cool was they can also say where it came from. Because a lot of these things can be very de novo, meaning they just created on its own, as you know. And so one of the things that's interesting about it now is if they can find it, and then they can say, hey, it's coming from the dad, then at that point, that it's not just something like a one-off, but hey, this is there. It might allow you to make decisions. So let's say you're like a same-sex couple and you're using donor sperm, or even a heterosexual couple that's using donor sperm. And we find this, now okay, I want to switch to sperm. And that was the other big thing that people talked about, is they were saying, if you have this information, you know where it's coming from. You can also do things like, if let's say you do use donor sperm and the quality is really poor of the embryos. Well, technically, you could sit there and say, well, where's most of the abnormal aneuploid embryos come from? Let's say paternal kit. Now you can choose to use different sperm, or go, well, nothing's going to change it. It's coming from me. In addition to that, it's allowing them people also look at things like, for example, contamination. So now you know for sure, like, okay, this is from a maternal source. This is from a paternal source. We know that there's no contamination. One of the things that we know is that in the United States, there are some situations where people have had embryos that weren't theirs. And some believe it could even be from contamination because, sorry, not theirs, wrong thing I said, apologize. That if they wrong gender or something like that, where it's their embryo, but they picked the wrong one, and then it's contamination from, let's say, like an embryologist, a female, and that contamination then causes the wrong embryo to be picked because they thought it was a girl, but it was actually contamination or something like that, so forth. So again, allows for better selection of that. So that was kind of a pretty cool thing. So the other thing that was, sorry.
Oh, no, I was just going to sort of like recap some of what you're saying here, Dr. Amols. I mean, it sounds like one of the interesting things that's happening, just for all our listeners, that I'm taking away from, because I'm back down at the clinic, you're at the conference, so but it sounds like what you're seeing here is that the tool is getting more precise, and it's also creating more opportunities to be potentially more accurate. So more accurate and more precise as they're adding on the SNP array along with the NGS, as they're trying to understand, of course, NGS can't identify triploidy here. We can identify that the source of contamination. So, in the background of all this, I think one question that's always emerged is, hey, maybe there's a little bit, it's not very high, but maybe there's a little bit of a, a false positive or a false negative rate. And so what we're hearing here is, is it possible that that rate is coming down a little bit with these new iterations of the technology?
Yeah. So, I mean, I think the one thing is that a lot of these little things are very, very small, right? So when you talk about error rate, there's not very large error rate to begin with. And then on top of that, even these duplications, like they're very small portion of cases. But again, anything that can help improve it, is great to hear. And what's unique about the Cuprigenomic ones is the resolution's higher. So usually most of the companies are using SNP technology are like 300 SNPs that they add into. And again, that allows them to have those copy numbers to find things like what are called triploides and things like that. In their system, it's close to like 150,000 SNP points, and even gonna be a little higher. So the resolution is really high to allow them to see some of these disorders. And that might then even lead to maybe further, things. But I just think it's great that we're looking beyond just the fact of, okay, is it normal or abnormal? Where, find this. Another really cool thing that was they're now looking at methylation, and they found that certain pieces of areas that are methylated, they can now determine which will be the best embryo to put back. And so when you think of like epigenetics, is a common thing people aren't familiar with is when your DNA says you should be something, but the epigenetics may change that a little bit. And so when someone gets methylated, it might say, okay, now don't do this. That was going to happen before. And when I looked at it, I talked to him for a little bit. I mean, he was showing me what their studies show, but there's still a lot to go on there. But I just again thought it was kind of unique how someone is taking PGT and trying to improve it in a way by looking for further factors. And so now you got PGT, now with SNPs, now you're adding methylation, looking at epigenetics on it to be able to help determine which would be the best embryo to put back.
On that same point, you're just reminding me of a company that's doing some really interesting things with epigenetics and sperm, and they've presented quite a few studies at last year's ASRM. I saw they were presenting it this year as well, and they're kind of trying to decide, hey, on the epigenetic, because usually a semen analysis is kind of all we have to look at men's sperm, and we know that some men with very high quantity of sperm have a hard time getting a pregnancy started, and some men with quite low quantities don't. And so there's a lot that plays into that, and this appears to be one more missing piece of the puzzle, if you will. And so what we have here is that they're kind of figuring out this epigenetic, let's call it fingerprint. And this company is at least trying to tell us, hey, is this person a good candidate to try intrauterine insemination versus is this really somebody that should go right to IVF? And it's an interesting question because, that's a clinical question that we all have, when we counsel our patients. And I think having another tool that can help us at that stage, so now we're not just talking about only IVF, but we're talking about, do you even need to start with IVF, or can you try starting with IUI by just looking at the sperm at a deeper level? And I thought that was very interesting. Now, obviously, one thing that gets back to us as physicians is the test even worth it, right? Because if the test is so expensive that you're just better off doing a couple rounds of IUI and that's the same cost, then it's sort of like, isn't it better to just try the IUI and see what happens if it's the same cost? So again, there's always this scientific element, very cool tools, cutting edge technology, but then in the real world application, is it worth it? And I think that's kind of where the rubber meets the road.
Yeah, and again, everything starts to go under scrutiny. So the thing about this conference is, I mean, you're hearing about things brand new. It's kind of cool, like, oh wow, it's cutting edge, and then later you find out it doesn't really make that big of a difference, or only it helps a small amount. The other area that was in PGT that people are looking at, well, I should say two more areas, but I think I would love to talk to you about these. One was looking at now diseases. And so actually there's a company called Genomic Predictions who actually does PGTP and looks at things like, what's the chance of your child having diabetes or something? So something that like runs your family. We're not talking a recessive disorder, but these are like polygenetic disorders where you have to have multiple different genes that lead to a disorder. But like, for example, let's say you're someone who maybe, dealt with diabetes, which are type 2, in your life, and you don't want your kid to have that high propensity of that. You could theoretically, using this find the embryos and rank them into which one has more likelihood of developing it. It's not an absolute yes or no.
Right.
We can do it. So there's more companies looking at that, which I thought was pretty cool. And then the second thing now is people are adding PGT and adding AI into the PGT, which seems weird when you think that. You're like, well, how's that gonna help? But looking at some of the data points again with the polygenic diseases, and then looking at the embryo, meaning the image of the embryo, they're able to even figure out which is the best embryo to put back there or aneuploid. So kind of like you got like the MyoSure scores. It's just another piece that help you pick up which embryo. And so everything is just trying to take all these different things we have now and kind of squeeze them all together and come up with products. And it was really neat. And again, I think in the end, I think we're going to end up getting something more different someday. That's going to be a combination of a lot of these, which ones are the best, which ones, as you said, really give the most impact in the end, because in the end, everyone's a baby, right? But where you see a big change now is focus on the healthy baby too. And so that's where a lot of focus was, and I thought it was really cool. Like I said, especially that it was going down the route of the PGT route. So
I mean, I think that's always been so fascinating, right? Like in our field, one of the really incredibly exciting things that we have the opportunity to do is to be at the forefront of preventative medicine, right? What better prevention than at the time of putting the embryo back in and having it start off life and having the best opportunity. And we're already doing some of that, right? I mean, inherently PGTA tests against certain chromosomal abnormalities, et cetera. And so I think we're doing a little bit of that already. I think where this becomes more and more problematic though is at some point we have too much information, and we know embryo number 1 is most likely to implant, but at the same time has a 62% chance of lifetime diabetes, and embryo number 2 is a little less likely to implant, but maybe that metabolic score, whatever it might be, is a little bit lower. And at a certain point, it becomes extremely difficult for our patients to really make a decision moving forward. I think it's already becoming quite difficult, as for example, just sex selection. I think some patients are burdened by the fact that they can make that decision, and and we don't want to keep them from making that decision. We want to give them that autonomy to make that. But I think, again, this is one of these things where the science is moving faster probably than the ethics, and faster than our society knows what to do. And I think our role as a group of medical professionals is to make sure that we are introducing the technology when people feel like they're ready for it and feel like they're ready to know what to do with those results.
Yeah, I think this is a great point here, and I think what we should do is ask this question to our audience about this, because using this, exactly what you talked about, I've had the situation where you go to have a baby and no one's like has a baby and goes, oh my God, it was a boy, I wanted a girl, I wish, I'm so disappointed, right? But what's crazy is people go through IVF, they're planning on going through one time, and then they don't get, let's say, one of the genders, so they all come back boys, and they're happy. You're happy to have a baby, but now they're like, I don't know if I want to do it again to have a girl. And so you're right, it creates this kind of thing that they would never have. But the question I'd like to ask the audience, so I'd like that question come in, is this. So one of the things, as Dr. Salem was saying, is that when we get more information, sometimes that information starts to make decisions hard. And one of the difficult decisions is that when you get a mosaic embryo, and some of these companies that have these very high resolutions have very high mosaic embryos. And one of the discussions I had with them was, I said, when at least the patients I've spoke to, is when they see mosaic, they assume abnormal. And in all fairness, it is kind of an abnormal embryo. They feel like they just got abnormal embryos, and they feel like, wow, what was the point of all this? And so one of the things I asked them was, I said, well, listen, if you have 2 embryos, and one is euploid and one is mosaic, and the mosaic had a better grade and the euploid had a lower grade, which one do they put back? And I asked the scientist this, and he again said the euploid. And this was one of my parts I was telling him. I said, listen, your technology is great, but you have this high mosaic rate. These mosaics are basically, patients feel like they didn't get a normal embryo. I'd love to hear from other people. What did they feel? People have had mosaic embryos. Did they look at them as like, oh no, it's just another embryo I have to use? Or did they kind of look at it as like was that my backup embryo now, right? I don't want to put that one back first. I'd love to see what you think of that too. What's your experience been with, talking to patients when they get that mosaic embryo, or get some embryo with a couple of mosaics, and maybe the gender they want is in the mosaics?
Yeah, I mean, this is such a conundrum. And this is, I think, definitely, again, one of these elements that the technology is giving people answers to questions they didn't ask. And so the problem here is that, I think for a lot of people, when they look at a mosaic embryo, they have a hard time distilling out whether, hey, is this just mean it's the genetic test is telling me something that is uncertain about the embryo, or is the embryo inherently bad in some way? And I think teasing those two things out is so difficult for most of our patients, because the genetics of it is really complex, and explaining that, even, it's understandable to that patients are a little, hesitant about it, or kind of question it twice or something like that. My experience, I feel like, with most of our patients is they treat that embryo as kind of a last resort embryo, right? Like, I'm done with everything. I don't have any more embryos. That's going to be the embryo I go to transfer, which I think is a reasonable way to think about it. But, maybe, again, they're getting an answer, in my opinion, to a question they never asked. And that's a problem.
Yeah. I had a patient of mine. I think she ended up getting like 9 embryos. Of the embryos, 4 came back euploid, and another 3 or 4 came back mosaic, and 1 came back aneuploid. And she even came to me. She goes, "How did I only get 4 embryos out of that?" So I'm like, "Well, no, you technically got 8." But I said that, but they're low mosaics and stuff like that, and they do technically have a lower chance, and it really comes with a lot of stress. I mean, because especially now, you can't even enjoy the beginning of the pregnancy because you put that embryo back, and you're worried that it might have that genetic issue that's in the mosaic. You might be concerned now about that until you can do some type of testing later on, CVS or amniocentesis. And so it was really interesting, because it's one area, as you say, as you get more and more data, you kind of get more and more noise, right? So the higher resolution, as you get better resolution, there still ends up being more noise. And so I think one of the questions that came up, and I saw on the Instagram, was if some labs have more mosaic, they said, regardless of the thresholds, and they're all using NGS, how is that possible? So their question was this idea of, well, wouldn't it all be the same? Wouldn't every company have the same mosaic rate? And it's a great question. And so I think I'd love for you, if you want to talk about a little bit about what that means by the threshold, so people understand, like, what's it mean to have a threshold? Because people always like to ask that. Well, how do I know it's not really mosaic? And and I said, oh, no, it's definitely not all the cells came back the same. But if you want to touch on that, and I think it's a great question they're asking, is what makes it different? Why does one have it? And that's a whole bag of worms, because it's not just to have to do with the type template they use.
Yeah. No, I mean, I'd love to take this one on. So this is something that I've been really fascinated with for a long time, because we don't have a standard across the industry of what we consider a mosaic embryo. And so it ends up being up to that individual company to make that call. And so, just to use like an example I like to give, imagine that when you biopsy the embryo, you just take, 5 cells, and in a genetically normal embryo, all 5 of those cells are normal. They all have 46 chromosomes. Everything is lovely. Everything's perfect. And then you have another embryo that has, those same 5 cells are biopsied, and they're all normal. Okay, well, that's abnormal. That's an abnormal embryo. That's an aneuploid. But what happens if you biopsy an embryo and 1 of the 5 cells is normal, or 2 of the 5 cells are abnormal? Well, first of all, we can't even tell that it's the 1 cell or the 2 cell. It has to go through this, crazy process where all the DNA gets cut up, and then it all gets amplified, and you're comparing the ratios of the normal to the abnormal cells, or the normal to the abnormal, snippets of DNA, I should say. And so as a result of this, the readout from the test is, yeah, I think there's one cell that's abnormal, or yeah, it seems like there's, two cells that are abnormal. And so what you come away with is this idea that it's a mosaic embryo. 4 of the cells are normal, 1 is abnormal. We believe this cell could go on to be a healthy baby, but it has a higher chance of not. And our clinical research would support that. I mean, people have, of course, transferred mosaic embryos. It depends actually on the chromosome that is mosaic, the proportion that is mosaic, all these other things. But we know that there is some very real, pregnancy rate and live birth rate from transferring a mosaic embryo. Now, is it anywhere close as high as a euploid embryo? No, it is not. But it's not zero, and that obviously, creates some hesitation with, discarding mosaic embryos. So I think this is a really, interesting and important part of it. Now, the big thing that you're talking about, Dr. Amols, and this is such an important point, which is the platform gets to decide what the call is. They get to decide it's a mosaic embryo, it's not a mosaic embryo. And there's no gold standard, if you will. It's not, a kilo of gold is a kilo of gold. That's not the case. And so I think that is a big issue in our field still, and that this idea of harmonization, where we need to kind of all agree what exactly is a mosaic embryo, hasn't been kind of totally sussed out yet.
Yeah, because if you drop it down to 5%, 10%, moving that will change it. But then there's even a step beyond that, obviously, right? So one of the steps beyond that is there's like the Lumina platform. There's different platforms out there, and we know some of these platforms create more mosaics. Mm-hmm. Now, when we say create more, again, is it something about the platform that creates noisy data or something like that? Because again, that's the thing. It is a little bit of a noise as well. I wish people could see the plots, but it's like these little data points, and you're like, okay, it looks like there's extra here, and it's very difficult to say for sure. But now when we're talking about, people are looking at even biopsies, like the way we biopsy them, the way we culture them might even be causing these mosaics. What we do know for sure is, if you take humans and say, what's the normal mosaic rate that occurs in placentas versus like the baby, because we have biopsies of placentas from CVS, we know it's much higher than what it should be. So we know they're not real, but we don't know how to tell which ones are real or not, and that's the hard part. And so the question they were asking is, yes, we do know that different platforms, so different companies are going to have higher mosaic rates than others, independent of where they set that range, because they're not all the same. NGS and NGS just has to do with the way you are looking at the DNA, but the way the platform does it is slightly different, and so for that it can create different ones. And so different companies have different. Some have almost close to zero. Some have as high as 30%. Mm-hmm. So I'm really excited here, because Steve Brooks is a brilliant guy. This guy is who's in our room here, the kind of chap, does tons of analytics and things like that. He asked a great question here. He says, what surprised me at the embryos analysis solutions don't also ingest the full PGT analysis, as they should improve the embryo assessment. So I won't bring him on because he's just great. I saw him actually at the conference. So it was actually the first time that we had to actually meet in person. So I thought that was really cool that we got a chance to meet. He's from Canada. So anyway, Steve, nice to have you on here.
Nice to be on. I always enjoy your show, Dr. Amols and Dr. Salem.
We're so glad you're here.
Yeah, what would you love to talk about? I mean, you always come up with some great thought-provoking things all the time.
Well, that was the one of the key points. I've always been wondering, and not just the embryo image analysis on time lapse, to also combine with the results coming out of PGT. So, without naming names, there's one company out there that does, provides both the embryo image analysis along in their time lapse incubator along with PGT, and are also working on NI-PGT. And they would seem to me to be the firm who can combine all three methodologies together, and ideally, to your point, reduce the signal or improve the signal to noise ratio. Yeah. That takes a lot of clinical trials, but it would seem to me that is kind of the one way to try to minimize the noise that's coming out of each one individually. I'd love your thoughts on that too.
Yeah, I mean, like I said, I thought it was fascinating now how we're taking all these different technologies and put them together. And I didn't even mention that, so thanks for bringing it up, because I forgot to mention about not just using AI in the still picture, but using AI in the time lapse, because again, you can do that. Matter of fact, I actually have a video I was going to show to everyone of an amazing time lapse I saw, super high definition. Like I couldn't believe how clean this was. I imagine AI can get more data points, but I agree with you. I don't think this is all going to be able to be through DNA. And
Yep.
this is one of the discussions I had with one of the PGT scientists, is that even what we're seeing is such a low resolution image in the DNA. I mean, we are not seeing every little piece. We're a mile up. And this is where some of, I think it's great for increasing pregnancy rates as we have over the years, but not to the point where we're going to be able to solve everything. And unless we can come up with a probe that can be so small to get every little piece of DNA, and then we'll be able to start looking at the source and stuff like that, which is very unlikely. That's going to create more noise. So I think AI is going to be a big part of this. I think we're going to be able to start looking at the analytics and stuff. And I'd love to see what Dr. is saying. I know he wasn't here and didn't see some of these things, but I know he's understands the concept. I wonder what you think as well.
I want to add one other thing too,
Yeah.
Dr. Amols, so that Dr. Salem can comment on this too. Is I'm sure you've seen, for example, what IVF 2.0 and now Conceivable are doing, and the ignoring the automation they're trying to do. I always thought the combination of using their AI sperm selection system to identify the best sperm in the sample after having done some microfluidics filtering. So taking the best sperm that you mobilize from their AI analysis of the movement of the sperm and the morphology, et cetera, and match that with the best AI assessment of the oocytes that are retrieved, that you're matching the best with the best, through kind of a sequence of prioritization. I'm not sure if I don't think there's ever been any RCTs really done on that yet, but I've got to think that will get just one notch higher in overall quality, particularly in the first 2 or 3 embryos that are created in that manner. What would be your thoughts on that?
Dr. Salem, do you want to touch on that?
Go ahead and take this one. I have another point that I wanted to make, going back to another point that Steve had made. But yeah, go ahead. Well,
Steve, I think the fascinating thing about that is that, when I first heard about fluid dynamic analytics of separating sperm, I didn't understand it, because we've always assumed the DNA inside of the sperm has nothing to do with what made the sperm, and it doesn't. We know that for sure. What's weird is that then what we found is that there's probably portions of the DNA that's opening up and being used to run the sperm. And so now, looking at those kinetics of the sperm movement, we're able to realize how well the DNA is it fragmented or not, right? And so I think that's what you're pointing to, is that yes, if we can have better sperm selection, because right now we really don't. Unfortunately, the only way you can determine a sperm is good is you have to kill the sperm first, which is obviously pointless. And so I agree with what you're saying. I think eventually, with all these different avenues coming together, we can find a way to pick better sperm that's going to help. The interesting thing about that was, I was looking at a lot of the data for PGT results, is that a lot of the results do come on the female side, but there is a lot of paternal side. And so I don't think it really all comes from the sperm in that situation. But again, we're looking at that very low resolution picture. I think maybe someday we can come up with a better way to look at the DNA. We might be able to get a better idea. But I do agree with you. I think the sperm has effect. I think it's going to benefit, but I don't know of an RCT with that yet. And I actually asked the guy who did the methylation that same question. I said, well, methylations could come from stressed embryos, and we know that embryos being stressed is going to affect them. How do we know that DNA fragmentation of the sperm, which is also an environmental issue, might not be the problem? So I was asking him, has anyone done the trial to look at, if you take sperm that's already been treated, as you mentioned, with fluid dynamics, and then did his study with the PGT, do they still get the same result the methylation. And he said they do, but a little bit less. So it was kind of interesting. Anyways, Dr. Sam, you said you were going to bring up a point.
Yeah, no, I mean, this is all very much related to what we're talking about here, which is this idea of introducing new technologies that are basically layering on another technology to what we already have. So the idea here being with AI in addition to PGT, AI in addition to, the embryoscope, or, just, time-lapse photography effectively. So the big thing that I hope is next is, NIPT, or like the non-invasive, genetic testing of the embryo in the actual media, in the spent media. I think the big benefit there is this idea that hopefully, if the data pans out, that we will be able to not do something invasive to the embryo. Now, we think that it's still, again, very safe overall and very good, but it'd be curious to see if we can, avoid doing that. Do we see even a bigger bump in implantation rates, or might there be a group of women who might benefit, disproportionately compared to other people, meaning those people with recurrent implantation failures? Are their embryos particularly susceptible to the embryo biopsy, things of that kind? Now, on that same note, I think what our field could do a better job at, quite frankly, is doing the randomized controlled trials first, and having it in always in experimental protocols, and repeating that trial before rolling out the technology, widely to the masses. And then, sort of the cat's out of the bag and everybody's using it, and it becomes very hard to actually look at it in a non-biased way. And I think this is just a challenge. Internally, this is a challenge we've had. We've had technologies that have been rolled out that, years later, people have gone back and said, oh, you know what? Technology wasn't as great as we thought it was. And I hope that we've learned from that. And I hope that, we kind of continue, all these iterations, but are also introducing them in the most responsible way possible.
That's kind of a cool question for Steve, even that is when you think of DNA problems, right? It usually shows up, right? So if someone has a disorder, we start to notice it on their skin. They might have a condition like neurofibromatosis. You're going to say, oh, wow, they must have that. So in some ways, I almost feel like AI, looking at millions of data points, might be able someday to really be able to determine if an embryo is euploid or not. Because if everything of growth is through the DNA, then if there's errors in it, it should show up. Now, the question is enough? If it's enough data points to figure that out, I don't know. But I even think, when you eventually have that metabolomics, you're right. We won't even have to take a biopsy, because if we just take the spent media, we might be able just from that alone with the AI say, hey, we have the same accuracy rates as if we took the biopsy. And I think that is, it's going to be a huge thing. So anyway, Steve, any other things? You always have very thought-provoking questions all the time.
No, I think that last point in particular, and the one that Dr. Salem said is I think really important, that they start to combine the signals. And I think, to his point, the non-invasive, and you would think the time-lapse incubator guys are the best guys to do it, that they do the NIPT in situ along with the time-lapse AI analysis to provide a really strong incubator product that combines it all in one at a much lower cost than PGT.
Mm-hmm. I mean,
yes.
Potentially, yeah. And so, yeah, we'll actually jump on that. But thanks so much, Steve.
Always glad. I enjoy this.
Awesome. I think that brings up a question, Dr. Salem, that, he mentioned about lower cost in PGT, but in reality, it's really not lower cost. So what I mean by that is saying, there is a limitation with time lapse. I found one company that actually had one that allowed 10 patients,
mm-hmm.
but the machine itself was like $130,000.
Mm.
And if you take, let's say, like Aztec or something like that, they have a machine for there with just a regular one without doing time lapse, you're talking could be down in the low 30,000s or something, 20,000. So it actually is very difficult for a clinic to be able to do it. And the amount of work that has to be done is slightly a little bit different as well. it actually increases cost. And so I think that's one of the reasons we haven't seen time lapse. Now, I think there is going to be a point where if they show that, yeah, time lapse really does allow us to not biopsy, I think we all agree that it will be worth the investment. At the time, probably costs will come down and stuff. But time lapse is one of those things where it's really, really fascinating. But it's very, very difficult to, I think, implement as like doing all your patients that way. And so I don't know. In my clinic, we've never had time lapse. But I, go to all the shows, I see it all. I'd love to see what you think of time lapse. I mean, have you had the pleasure of using that at any of the clinics you were at?
Yeah, we have, and I'm fortunate enough to be a part of quite a few studies as a fellow with time lapse, and it is a really interesting tool. It's very, very cool as a reproductive endocrinologist and sitting in the lab and looking at these images. I know you're going to show us one later. And it just hasn't done quite enough, I feel like. I mean, I'm not saying it will not. It just feels like when you add on all the clinical, criteria that we're using, all the ways of optimizing, using the genetics, using, all these kinds of things, I feel like there is a possibility, there's a realm in which like time lapse could improve beyond that. It just, the incremental increase is so little. And it's exactly getting to your point, which is it worth it? Like, is it worth, if it makes every IVF cycle cost an extra $1,000, is it worth introducing this technology? And like, the short answer is like, doesn't look like it so far. And that's a really hard part of our jobs, is kind of making sure that, things are value add. I think the interesting thing about genetics is that the rate at which genetic technology is improving and the cost at which sequencing is coming down is faster than Moore's law with computational power and costs. And
Correct.
So that's wild. You think about the fact that your iPhone has more computational power than a supercomputer would have had, what is it, 30 years ago or something like that. My numbers might not be right here, but it's amazing to think that the genetic technology and the cost of genetic technology is even more impressive than that. Now we're not all holding a DNA sequencer in our hand and throwing it in our backpacks, and that's why we're not into the technology. But I think that part is very interesting. The fact that we're making these huge strides with genetic innovation and genomic innovation and sequencing. And there's a company that speaking of ASRM and advances, that's sequencing the entire embryo, doing the complete genome sequencing of the embryo as opposed to just little snippets. So, and they're doing it for a fairly affordable cost, but again, that it's still quite a high cost.
Yeah, and to your point, I mean, I think the reason it hasn't, you're right, Moore's law definitely going to prevent it from ever keeping up with the technology of looking at the DNA. But part of it is when it first came out, it was really cool. But in the end, you couldn't really predict which embryo was the best. I mean, in the end of the day, it was still biopsy. Now with AI, it's definitely getting much better. It's still not as good as biopsy, but it's getting close. And I do think there's a point when it does have the same accuracy as, let's say, testing. There are some patients who would benefit. I mean, we all know that there's those patients just have very fragile embryos and stuff like that. There might be some benefit to it, but I know the 130,000 sounded like a lot, but it actually used to be over 200,000 when it first came out. So it just shows you it has come down, but it's just still so expensive. I should have taken a picture of this machine because I mean, it's unbelievable. The space it takes up too is so much, and so you'd have to have these gigantic labs to build around all this stuff. But actually, I think probably good for us to show this video because it really is pretty impressive. If you have a chance to see this. So this is, a embryo, say it's dividing. And I know on the phone, it probably doesn't show how impressive this, but this resolution is really good.
It's beautiful.
If I had the audio on, you would just hear us all in the background going, this resolution is insane. Like we couldn't believe how clean this was. All the little points of data that you could potentially see. And this is a new company out of China that was doing this. And it was like, it was so impressive. The camera was actually one camera that goes around to all the different ones and constantly keeps taking these pictures. And this is a 2 times video over 126 hours. But just thought it was something really cool that everyone should be able to see. So then the other thing, and before we get on to, I want to kind of next thing is, someone asked, is it recommended, here, we'll put this up, is it recommended to transfer mosaic embryos with good quality embryos or by themselves so they don't interfere with the chances of the better embryo? I know we've touched on this before in another show. If you want to kind of answer that one, I'd love to kind of go on to some of the clinical stuff that was there as well.
I think I just missed that question there.
Oh my goodness, my fault. I knocked it off. There we go. So basically, do we put back an embryo that might be mosaic, or this idea of, do we put back a bad embryo with a good embryo, and will make the good embryo not implant? Will make it not work? Is the question?
Yeah, no. So I mean, the embryo inherently doesn't make another embryo, not implant. I think one thing that clinically some of us might be concerned about is if you put one mosaic embryo, let's say, and it unfortunately leads to a miscarriage, and then there's another embryo that's there that did in fact implant and it's going along well, would that potentially, that miscarriage, increase the likelihood of the miscarriage of the good one? And that's something that's, I think, we're always a little bit concerned about. I think the other part of it is, well, if you already have a good embryo, I mean, the ASRM guidelines are, you transfer one good embryo at a time. If it's PGTA normal, you transfer that one good embryo at a time. And so that really is still your best bet of a healthy pregnancy, is that one good embryo. And then if in a later round you need to transfer the mosaic embryo, you would sort of, transfer it separately, is usually what people are doing now. Are there gray areas? I mean, you transfer, maybe you have 2 mosaic embryos, you transfer 2 mosaic embryos, things of that kind. You maybe have one embryo that didn't test and one mosaic embryo. And this is why the human element, of talking with your doctor and going through your exact situation is so important, because there's so many variations of this. But what's your take on it, Dr. Amols?
Yeah, I think exactly what you said. I think that the evidence is clear, that an embryo being there is not going to hurt the other one. Whether, if it goes away and it dies, it's not going to hurt that embryo. That part we know for sure. We do know, though, if you put 2 embryos back and both take, you have now twice the risk of something going wrong. So there is, as we've talked about before in prior episodes, that one embryo transfer might be here, which your chances are 2 might be here, but doing a cumulative rate, the second transfer with 1 is actually higher than putting back 2, because you only have the risk of that one embryo. If one embryo has a subchoric hemorrhage, you could lose the pregnancy. But I even say it goes a step further, and I would say this. Anyone who's been through infertility can understand this. It is scary as hell, man. I'm telling you, like when you struggle to have a baby and you finally get pregnant, you almost start to think in your mind that something bad's going to happen. Because you feel like, how could this happen? I've had 3 years, 5 years with my partner. We've never got pregnant. Everyone else looks at their partner and they get pregnant, but I haven't. And this fear of like, I'm going to lose my pregnancy. So when you put back a mosaic embryo, it's like putting this little bomb that could blow up in some ways. And I feel like you can never then enjoy your pregnancy. Obviously, you put back 2 mosaics. Yes, you're worried about both. You still have the same. But imagine you put back this euploid embryo and you put back this mosaic embryo and only 1 takes. Now, you don't even get to enjoy that right now. Now you're sitting there going, oh my goodness, which embryo was it? Was it the one that was euploid? Was the one that was mosaic? And now you're worried that, in the first portion of pregnancy of like, do I have the healthy embryo? Now am I going to have a miscarriage? Because I know I have a higher risk of miscarriage. And I just feel like it's not worth the stress of having to worry about that. And so I do recommend people not to put back a mosaic embryo with a euploid. I think it would create too much stress. And I've had that happen where people have still went against it. One embryo took, and yeah, they were nervous the whole time and worried that they were going to lose their pregnancy. So one of the things I wanted to go on is that there was a lot of stuff for patients. I thought that was really cool. It was 2 things I want to go over, and I know one of them is your love. So you're going to love this one. But what I saw was a lot of stuff for patients. So I'm going to put this on the stage again. I don't know how well it does, but This was one that was looking at early detection of endometriosis. And so using blood draws, they were looking at detection of endometriosis. And we've had this discussion before where, people want to do like Receptiva to find out if they have endometriosis. It's not really as good. So what this does is it takes someone who has already a risk of endometriosis. And the benefit here is it would allow us then to be able to determine if we need to take this person to surgery or not, and obviously there's other factors that involve in that, but it's just another tool to be able to determine without maybe having to go to surgery, or if we feel like, they're having lots of pain, we think there might be a cause of endometriosis, then now surgery is worth it. But if this comes back showing they don't have endo, then you say, well, maybe we won't go to surgery. So it's just, I thought it was a really cool thing that they had. What are your thoughts on this? Again, this early detection, be able to find endometriosis. Again, not even really with fertility, just endometriosis. I don't hear. Are you saying anything?
Yeah. Sorry. It just was. Yeah. I think, the early, identification of endometriosis is definitely a holy grail in my opinion, right? Because it goes undiagnosed for so long, and so any sort of opportunity for that is just incredibly important to guide our decision making. So super exciting one there.
Yeah, and after that, again, it got another thing. So then this was one I thought was really cool. Lots of ASRM. And, ASRM is not a very common thing, but you and I were having a discussion a while ago about how there are things that have increased, which I'd love for you to talk about. So there was two things that they had for ASRMs. One of them is this company, which what they do is they take the person's own blood, unlike PRP, who have failed PRP, they use CD133 DNAs. And let me see. I think this was one of them. Again, it's hard to read these, so I apologize. I wish I could make it bigger. But as I said, it's treatment based off of human autologous CD133 bone marrow derived stem cells. And basically, they don't use the bone marrow, which is kind of interesting. They get the same cells, but what they do is they put the person on like Humira, and they try to get them to build up more of these cells, and then they extract it from the blood, and then they don't put it in the uterus. They actually go through the arterial artery, and then it allows the cells to get to the uterus to be able to help. And it's very specific for each patient. So it's when you talk about customized treatment, it's amazing. So I thought that was cool. And then there was one more I wanted to show. No, that's not it. It's not it. I guess I don't have the picture of it. We'll get to this next, which was in the past, if people don't know, when you did surgery in the uterus, there wasn't much you could do. You did stop it from rescarring. And so there used to be this company, Cook used to make this catheter that was like more heart-shaped, kind of like a uterus, like a triangle. But even then, it didn't get to all the crevices. And then after that was gone, people would just take a Foley balloon, which usually goes in the urethra, blow it up, and be this ball in the uterus. And I would actually go in the surgery. I don't know if you ever saw this stuff, Sam, but you go in and you would see the cavity look like a ball, like it scarred in all the areas where it wasn't. It was like, oh, you can't even see the openings to the tubes. So what was cool is they have this new device, which uses a wire-based gel, a polymer, and at the end of the procedure, you push it into the cavity, and it goes into every crevice, fills the whole uterus up. And what's great about it is it just stays there for up to about 3 weeks, and then liquefies and just comes out. Looks like a clear fluid comes out, so no one even notices it. Again, whether that actually works or not, that I don't know. I mean, obviously, we have to look at CRT studies, but it was just kind of cool. I thought, wow, pretty awesome. Someone thought about that, a way to prevent scarring versus other techniques where you just put it in there and hope it does something. So I'd love to hear your opinion on that, and then we'll go on this last one. But pretty cool. Huh?
I think the wonderful thing about ASRMs is kind of very intense scarring of the inside of the uterus, leading to miscarriages or women not being able to have implantation of the embryo. The fact that we're making progress on a part of the field that feels like we haven't made progress on in a very long time is very exciting. It's almost, I don't want to say ignored, because a lot of us treat ASRMs in our clinical practice day to day, but the way we treat ASRMs today looks very similar to the way we treated ASRMs 20, 30, 40 years ago. And I think the fact that there are these new things that are, providing improvements on top of what we're already doing surgically is really, really interesting. So yeah. I think we have one person who's on that wants to bring on a question as well here.
Oh, we got the microphone working now?
Oh my gosh, I feel famous. Can everybody hear me? Or
You are famous, Samantha.
Thanks so much for
hi,
coming.
Dr. Salem.
Hey there, how's it going?
Good. So, well, I feel kind of bad because my topic now is like from 15 minutes ago, but I was just curious if with all the everything you've been learning at your conference, AI, learning more and more about embryos, what you think in terms of like, will this have a political impact? Will we have more legislation and issues with access to treatments if we know, quote unquote, too much information?
Wow, yeah. Great question. Great question. I don't know. You want to tackle it first? I'm happy to kind of chat about it as well, but
Yeah,
Because
and it's
I personally, like, I sometimes am like, I don't know that I want to know that much.
Mhm.
Because I'm like, oh my gosh, if I was an embryo, would my parents have, quote unquote, picked me,
Yeah.
that's a really great point, because I can guarantee you, my parents knew I'd look like this. They probably wouldn't have picked me beforehand. It's a really great question you asked, Smith, and I think that's always that kind of like ethical dilemma, like how much information is too much information, right? I mean, at what point, if your kid's not going to be fast enough, if your kid's not going to do this, so I do think there is, like anything, when the pendulum swings and we start going one way, everyone starts to say, okay, wait a second, we might be going too far, and then we really do make limits on it. And I think that's going to happen. This same thing actually happened when a long time ago, they were able to look at things, at some DNA things. And there was actually a person who had a disease. And they knew they could find this. And someone that had this idea said, hey, why can't you just let me know which kid is a girl or a boy, so I can not put back a baby that has this disease? And there was a big ethical dilemma with this. Everyone was like, hey, you can't do that. You can't pick an embryo. And they're like, well, why not? Why can't you? You're picking off a grade and stuff. Why can't I not have my kid, have this disease? And so, that was a big jump then. And so you're right. I mean, it is kind of the wild, wild west right now. We really are doing, I think it's a very, very good question, is how much is too much information? I think where the information, I think Dr. Salem, I can say for him, is that anything that's going to help you get a healthy pregnancy. And again, we have to define healthy, obviously, and affordable and accessible to everyone is really the goal. But there's a second part to your question. I think you were asking, correct me if I'm wrong, Samantha, but which is, how is this going to affect, because it kind of sounds like you were wondering, like, with our political environment stuff, like, are people going to be then more against it? And what I can at least tell you is this: most of the country is very supportive of IVF. There's actually probably less than 1% of people who really don't support IVF. Now, there are religious groups who don't agree with it, but they're not against it. That's two different things. But I think you make up a really good point. I think there is a point where the pendulum can swing so much that a regular person, even myself, I think there will be a point where I'll say, hey, I'm not okay with you not putting back someone just because they're not going to be an A student. Like, to me, that would be wrong. So,
Well, and I think like we also have to realize society functions because people have different skills, different abilities, different ways that they look or whatever.
Absolutely.
Great question. What do you think, Dr. Salem?
I think, I'm so glad you asked this question, Sam. I mean, this is just like it's a great point that you're making about our field as a person who isn't working in it day to day, but is interacting with it. And the idea is that, how much information is too much information for patients, and I don't say that from like a paternalistic way, like, we can't give them, they can't handle the information. It's like, no, like I myself as a patient, like, I don't want to know everything, that's coming down the pipeline. Like, I don't want you to necessarily tell me I have a, 32% chance of this, that, or the other, like it's not information I can use. And I think in our field, one thing that's hard is the technologies are moving very, very quickly, but they don't always reflect what people want. And it gets back to this thing that I was saying earlier, which is patients are getting answers to questions they never asked. And that's where, as a field, we have to self-govern ourselves a little bit and say, hey, this is not, just because we can do this doesn't mean we should do this. Now, one thing that's really nice about medicine in general and our field in general, in the US, is that the field has done a pretty darn good job of governing itself and saying, this is okay, this is not. As a group of scientists, physicians, patient advocates, etc., we agree that these things are okay. And by and large, what we've seen is that, again, by and large, the sort of government, the government, when we're talking about, the elected government, has generally not interfered with that too much. And I think that is what I hope to continue seeing personally, that we kind of self-govern ourselves responsibly.
Yeah, what a great question, Samantha. Thank you so much. I mean, like I said, that was a really, really great insight.
Well, and I think like the last thing I'll say is, which has been interesting, is how many people are like, oh, well, are you going to choose a boy or a girl? And I'm like, it was a fun question in the beginning, and it kind of becomes not very fun after a while,
Mhm.
So
Yeah. Other countries don't even allow it. So
Yeah.
we have actually people come to us from other countries. And I'll be honest, even ethically, I don't know how I would feel if I knew someone was wanting to put an embryo back because they didn't want to gender.
Yeah.
Normally the situation I deal with is more someone that has a lot of genders in one and then one puts an embryo back. But I don't know if I'd feel very comfortable, if someone said, well, I never want to have a girl or something. I'd be like, I don't know if I feel comfortable with this, like
Yeah.
that would kind of go against a little bit of my ethics. So
Yeah. Well, thanks for having me on.
Thank you so much.
Samantha.
Yeah.
So I got two more things, and then I probably have the most important thing I saw at this thing that I think
Okay.
it was, to me, it was the most impressive. I was like, this is amazing that they made, but I wanted to say that for the last, about that Apple one more thing, So I wanted to show this one thing. I really like this, and again, I don't think the picture does any good. The company is Fertile. You guys can look it up. It was actually a scientist who she didn't want to do IUI. She really wanted to jump into that. And so she said, I wish there was a way I could just do a insemination at home. So there's a little bit more benefit than just with intercourse. Now, although, I think you and I could easily say as scientists, like, how much does that make a difference? It depends on the sperm quality and stuff like that and things like that. But what I thought was really cool for is there's a big population of people who either have difficulty having intercourse, have vaginismus, have severe pain. And this was actually really cool. What she did, she came up with a unique way of injecting the sperm into, not into the vagina, but really close to the cervix. And so really neat thing. And I saw a lot of this. I actually saw a company that went, and now I don't like doing timed intercourse cycles. So one of the things I don't like about them is I'm not doing anything for the patient. I feel like I'm not even being their doctor. So a company came out with a way now where when they're doing timed intercourse at home, we're getting all the readings from every single strip they do and help them know when to have intercourse and stuff like that. So again, a lot of patient driven stuff. I thought it was really cool. And this is one of them. And I really hope the best for this, this person. She's very, very smart scientist, and you definitely should check it out if you guys are looking at this, especially if it's someone who doesn't want to do IOIs or maybe not been ready to see a doctor yet. In the first 3 months, just want to improve their chance a little bit more. That, again, it was something kind of neat. But the thing I thought you would think is really neat, and again, one of your loves I mentioned, was there was a lot of companies with regards to making things affordable with regards to like financing. And again, I know not everyone needs finance. Hopefully you have insurance, and hopefully when one of these two candidates win, they really do follow through and make IVF a mandate. But if that doesn't happen, there were some really cool companies looking at ways to make things affordable. Whether it was, let's say, for donor eggs, one of the companies would go and have someone go through, and you paid that girl to freeze her eggs, but then you got some of them. So you split the cost. There were companies that went, some of the companies that you had me talk to and other ones talk to, that ways to have full 100% refunds to the patients and stuff like that. So it was just, I thought that was really nice that, it's not just on us, but it was about for the patients. And there was even companies out there come out with generic drugs. I have one company that, impressively reducing the cost of drugs. So it's just nice to know that, just like you and I, who want more accessibility, want lower cost, there were a lot of people there with products like that. I was blown away And I think it's going to allow us to make things more affordable and more accessible. So, like I said, I know you weren't there, but I thought it was really cool.
That's
Before
awesome.
I show this most amazing thing, and I said I think we got one more question on the back here that maybe we can ask before we go on this and show this most amazing part. The question that came up here was off topic, but is treatment for IVF different if been diagnosed with Hashimoto thyroiditis or certain medications need to be on? So I don't know if you want to hit this one, Dr. Salem.
Yeah, I mean, the short answer is it's important to be treated for, Hashimoto's or, hypothyroidism as you're going through. It's a critical thing that if not treated, it can increase the miscarriage rate. So, whenever we do IVF, we're not just working in a silo, Dr. Amols and I, we're taking care of everything to optimize that IVF cycle in addition to that person's medical, that person's medical condition. So yes, 100% would it's not off topic at all. It would be treated. So short answer is yes.
Absolutely. Well, again, I had a fun night. Really appreciate everyone who came on. And I said, it's always great to talk to people. Again, I thought this was amazing. You may not, but to me, this was probably the best thing I saw at the conference. Let me move this to stage here. So a laughing sperm. I mean, I felt like if there's anything that's advancing us in this field, this was the most important thing I saw, and I just felt everyone had to have a chance to see that. So anyways, thanks so much for coming on tonight. I know I'm out in Denver here. I'm going to go grab some food after this, and then I'm going to head back home tomorrow. But thanks for coming on, and thanks for everyone who comes on it. Like I said, we really, really appreciate it.
Thank you all. Have a great night.
Have a good night, guys.